Great, thank you, Ansar. Yeah, I'm really excited about this new stent technology and wanted to formally present this to the group and demonstrate what we're talking about here in the setting of acute type aortic dissection. So I'd like to focus mostly on that, but I'll give a brief overview of aortic dissection and more contemporary care and specifically surgical management of type aortic dissection. Yeah, so thank you very much, and I will keep it. I'll go through these slides fairly quickly. So I'll just give a history background. First description of aortic dissection back in the 1700s, and I think we are all fairly familiar with the pathogenesis of this. As I said, I will focus on type A dissection. I'll go through the classification a little bit, but pathogenesis being a primary intimal tear, or an intimal tear is the primary event in the ascending aorta. And recently, and also the theory of intramural hemorrhage due to rupture of vasa vasorum in the media with the intimal tear as a secondary event. I mean, this pathogenesis really is, the outcome is the same, essentially, with the resultant treatment the same as well. Risk factors we know include abnormal aortic media in connective tissue disorders, Marfan syndrome being the most common, and those who have aortic dilatation, familial or otherwise, and those include those patients with a bicuspid aortic valve. There's changing theories on how to manage the aorta and bicuspid valve, so that'll be another talk, and we'll get into that in terms of threshold for surgical management of the ascending aorta and bicuspid patients. But aortic coarctation, again, I know Chris and I we've discussed a couple cases recently in patients with aortic coarctation, and again, tend to be more aggressive in replacing the aortas of these patients because of the abnormal aortic media. Again, I really covered this already. Bicuspid aortic valve, aortic dilatation, connective tissue disease, and a family history are all significant risk factors for aortic dissection. Again, the intimal tear with secondary extension into the media and propagating during pulsatile flow. Classification, there's two types, DeBakey, using type 1, type 2, and Stanford type A and B. Stanford classification has been more commonly utilized recently just because of the treatment being primary surgical for type A and primary medical for uncomplicated type B. We've gone to use the DeBakey type classification a little more, especially with this using the AMDS stent, which I'll talk about, because really the indication for using is really type 1 DeBakey rather than type 2 DeBakey. So you don't really use it in type 2 DeBakey type A dissection. So we are using that classification a little bit more now, just a pictorial representation of type 1 versus type 2, because really this stent it's really an arch remodeling stent. It's arch remodeling therapy, and that's really the essence or the take-home point of this stent, which I'll continue to reiterate and reinforce later in the talk. So, in type 2, the arch is essentially normal and not dissected, so we wouldn't use it in that scenario. Again, ascending dissections tend to be much more common than descending dissections. And complications, and this is important because we are potentially treating malperfusion and branch vessel compromise with this stent, particularly in the arch and downstream as well, as remodeling takes place in the distal aorta. And we do see remodeling even beyond the stent graft. Our studies have demonstrated in the abdominal and visceral aorta. And this becomes important in managing patients who present with malperfusion. Malperfusion in the form of malperfusion of the brain in the form of stroke, malperfusion of the spinal cord in the form of paraplegia, and malperfusion of the renal arteries in the form of renal failure and gut ischemia. Just to reiterate, the goals of surgery are, and this has been a standard dogma for a long time in cardiac surgery: excise and remove the intimal tear and obliterate entry into the false lumen proximally and distally. This is really the essence of a surgery in type aortic dissection. And you can imagine you have two lumens now, both being perfused. And really the goal is to remove the flow from the false lumen, have it depressurized and not have any pressure in it. And that's what will contribute or lead to negative remodeling. And then finally reconstitute the aorta. Yeah, so, and I think, this is one of the take-home points is, today in today's surgical world, this is still one of the few operations where we do on a regular basis that has a very high mortality still, it's in, 12, 15, 18 or more, 20% more mortality rate. So clearly we can do better in this operation, and a lot needs to be done and looked at to try to improve the outcome in these patients. And why are these patients dying? So integrated approach to managing this includes rapid admission to the hospital, to your center, to the operating room. Neuromonitoring is absolutely key. Stroke can be common. Open arch repair, and I'll get to this in more detail shortly, utilizing antegrade cerebral perfusion and axillary plus or minus femoral cannulation. Yeah, I'll get to that. And then circulatory adjuncts with an open aortic arch, as I said, with hypothermic circulatory arrest, that's HCA. And we don't really use retrograde cerebral perfusion anymore, but antegrade cerebral perfusion, and reconstituting the distal arch and the distal ascending aorta in the arch. So most important is a systems-based approach rather than multiple individual idiosyncrasies. And I think this is what we're trying to develop. And this is the essence of surgery. And you see the intimal tear here in the middle, and this is the aorta itself transected, and the aortic valve down below with the coronary ostia. And you see two lumens, true lumen and false lumen. And again, the goal is to excise and remove this intimal tear and depressurize, remove flow from the false lumen, and reconstitute true lumen flow. And this is generally, so this is important for how we manage the distal aorta, and this has implications for how we utilize the AMDS stent, and also detailed photos of the AMDS stent. And this is how I do, there's different ways to do this, but this is how I do the distal anastomosis. We generally have in the past before the stent with a neo media being formed by felt and bioglue, generally forming a robust anastomosis such as this. And that's what I do in the root. But we'll just stick to discussing the arch, because that's where the AMDS stent graft is applicable here. And this is the end result, essentially, and how we would perform a standard type aortic dissection. The problem with this, if you picture this as the outside, and this as the pictorial representation of what's happening at the distal anastomosis, and this is the essence of what we're trying to fix here. You see, there still can be potential for flow in the false lumen when in a type 1 DeBakey type aortic dissection, when you do the distal anastomosis in this fashion. And it can be a challenge and difficult to close the anastomotic entry tear. And as you can see with the arrows here, in this setting, the false lumen remains, continues to have flow, remains pressurized. And we often, this is kind of a standard, you guys will know, when you do a CT afterwards, the true lumen is small, sometimes almost slit-like, and the false lumen has the majority of the pressure and flow in it, with almost true lumen collapse. And this is where you get malperfusion and, more importantly, remodeling. And I can tell you this is not a trivial or insignificant factor, because up to a third, and more very contemporary recent studies show that up to a third of type aortic dissections that survive come back with aortic arch aneurysms. And this is the negative remodeling we talk about, because these arches grow and then they have to come back for a redo operation 5, 8, or 10 years later. if they're fortunate enough to have survived. And that's, as you know, is a very, very big operation associated with a lot of mortality and morbidity. So if we can avoid that negative remodeling, that aortic arch growth, and them coming back, then that would impact on their lives very significantly. So again, we discussed it, and this is what we call, it's a relatively new concept. We call it DANE, or DANE, the distal anastomotic new entry tear. And it's a relatively newer concept in aortic surgery, and I think it's a real physiologic anatomic thing that's been demonstrated. And clearly, studies have demonstrated it leads to aortic growth over time and decreases patient survival and longevity, and as an increased risk of reintervention, as I stated. And data have clearly shown that sealing this distal anastomotic reentry tear improves survival over time and promotes negative remodeling. And here's just another, I have this slide, forget about the stuff on the right, but I just wanted to show you on the left, sorry, how this can occur in a pictorial representation, and how you have maintenance of false lumen pressurization flow and true lumen collapse, and subsequent aortic growth. So in summary, sealing this does improve survival, decrease aortic growth, results in positive remodeling, and reduces reintervention rates. So what's the fix for this? So this is an interesting story. This is a cardiac surgeon from Florida who felt very strongly about this concept, and really actually left cardiac surgery to start this company on his own, really just from scratch, just to build this single stent. And I met him several years ago when he was just starting out, and he was really extremely passionate about it, and has seen it through to fruition with a lot of work, and has developed this stent called the AMDS stent, and called his company Ascyrus. His boy is actually named Cyrus, so that's how he got the name of his company, the Ascyrus, and that's AMDS, Ascyrus Medical Dissection Stent. And as I said before, it's really an arch remodeling hybrid stent graft. It's made of nitinol with this cuff at the end, which you sew, and I'll show you, hopefully the video will work. And it's designed as an adjunct to the standard type aortic dissection repair. So again, this is not a setting where advanced aortic techniques are necessarily required. And one of the greatest benefits of this is it's quite easy, simple to use. And really, one of his main goals was to this does not have to be done by an aortic surgeon or an endovascular surgeon. This is really for any cardiac surgeon to be able to use in a fail-safe manner, and I think he's really accomplished that. So the principles are to seal this anastomotic, distal anastomotic new reentry tear, the DANE as I called it, induce positive remodeling, manage the malperfusion, and as I said, it's very simple to use and does not add a lot of time to the procedure. It's an uncovered stent, so there's no risk of covering arch branches or causing spinal cord malperfusion and paraplegia. And this is just another pictorial representation of the stent itself. It comes in 4 different sizes. I'll get through this. The sizing is extremely easy as well. And again, it's very time efficient. It's very easy to implant. You don't need any wires from below or above. And really, it's just minutes of deployment. So, and this is the principle here. So you really seal this anastomotic entry tear here, and really, and there's no way blood can get into that false lumen, and it completely depressurizes it, and over time it disappears. And that's what I mean by positive aortic remodeling. That false lumen disappears, and on CT scan down the road, you almost see a normal aorta with no false lumen and all true lumen. Measuring is easy. You really just have to make 2 measurements, and the company recommends measuring the aorta at the level of the innominate left common carotid, and then once more in the proximal descending aorta, and then you can use this chart to pick your size, and it comes in a tapered graft if the distal aorta is small. Anyways, I won't get into the operative technical details, but suffice it to say that the sizing is relatively straightforward. And as is the intraoperative management of it. We haven't done one yet here. We've had a couple of close candidates. So our goal is to start using this here immediately. And as it stands, I've tried to, if I'm here, to assess every type A dissection and assess its suitability and candidacy for this stent. And because there is a trial involved and we are part of the registry. So and essentially with every dissection we have, I speak to Ali, who's the owner and developer and CEO of the company, and ask him his thoughts on using this case. And there's been issues with other dissections we've had recently haven't been particular candidates for one reason or another, but we do hope to, we're very eager to put one of these in and start doing it. And we're one of the very few centers in the country doing so. So I'll show you a video. So essentially it comes mounted after you pick the size, you insert it down the true lumen, and with 4 corner sutures, you tack it down to the entire aorta. And then you sew it circumferentially, and then it's deployed, and then you sew it circumferentially, and then you sew your graft to that. So you can see in this picture here, it's quite, you end up with a very, very robust seal and anastomosis. Okay, let me just show you this video. It's just a couple minutes. I hope this works. Is that working? Can people see that?
Yeah, it's working great, Zlatko.
Good, okay, thanks. I think this video shows everything you need to see. So there's the tear, there's the dissection progressing, and this is, and there you see, you know, flow and pressurization of the false lumen. So this is intraoperative management. You make your incision a little bit more flush rather than hemi-arch style. Well, this is what we would normally do, but and then you see persistence, potentially persistence of a re-entry tear there. And this has been documented on postoperative CT scans. This is not sort of just a anecdotal observational thing. And this is the device that comes on. It's very simple, easy to use. And like I said, you don't need a hybrid room. You don't need radiology. You don't need fluoro at all. This is just, you just size it beforehand. You pick your size. It comes out of the package, and they hand it to you. And no wire. I mean, you can use a wire from below, but it's absolutely not necessary, and it's not recommended. So you do your a slightly different incision. You advance the device, and it goes down quite easily. It's curved already. And then you bring that you bring the PTFE cuff flush, and you remove that device there, and then you see the cuff there. It's not deployed as of yet, and they do recommend using a felt strip around. Some do, and then you, like I said, you tack it down with 4 sutures just to stabilize it and ensure it doesn't move. And then it's deployed. We're pulling this green knob. And then you see the stent graft being deployed. And it's got a good radial force, so it does really expand that true lumen. And then you do a running stitch to seal it, and then you do your graft as you would normally. So really that part takes, that whole sequence of events takes less than 10 minutes. And this is your end result with false lumen depressurization and negative aortic remodeling. And no arch growth, no arch aneurysm, no surgery down the road. And, that's a CT representation of it. And as I said, there's a national or an international registry. Europe's getting involved. And there's 5 or 6 centers in Canada, and we're one of them.
Well, okay. Well, I have the daunting task of finishing
sorry.
a.
Sorry, that's the YouTube going on there. Sorry.
Let's close out your YouTube.
So we're back on track. So we're part of the DARTS trial, dissected aortic repair through stent implantation. Part of this early data have already been published, demonstrating really the results are really impressive. And it's been and then speaking to Ali and people who the few aortic surgeons who put these in, everyone is extremely impressed by how this works and how well the patients do, the low stroke risk, the low stroke rate, the remodeling, and what the CTs look like down the road. It's and this is I think the aortic community is extremely excited by this, and it's really one of the bigger changes that have come in the field of aortic surgery of late, despite all the new stent technology. I think this is one of the more exciting things, and I think the aortic surgery community at large agrees. So just to summarize, this new stent graft is now and becoming more and more so a very important adjunct to surgery for type aortic dissection, and I think will be obligatory down the road, supporting it as it supports the true lumen. And like I said, the goal of this is right from the beginning was so every surgeon can do it, and it's easy to deploy, minimum risk, easy to size, no hybrid room, no wires, no interventional radiology, no fluoro required. And I think the benefits of this are really huge in terms of minimizing these people who come back with arch aneurysms down the road and avoiding that big operation. Okay, I think I'll leave it there if there's any questions.
Perfect.
Thank you very much.
Thank you, Zlatko. That was excellent. Appreciate that. Nice overview of aortic dissection surgery, and more specifically the AMDS stent. Question for you. Just what are some of so 2 things. What is the process here? Like, if there's a type A dissection that comes through, should we notify you as soon as we know so that you can start looking at the imaging and determine whether or not this patient is a candidate? And then the question number 2 is, what are some of the issues you have encountered that have made the patient a non-candidate for this particular stent?
Right. So the couple we've encountered, I'll answer that in reverse order. So one is if the arch is big, right? Then the arch has to be of normal size, because then you're not doing the right operation. If the arch is big, then it needs to be replaced. So so you don't need the stent in the arch. Now you could replace the arch and still put this in the distal descending aorta, but that's really getting off label a little bit here. So we're not doing that in this scenario now. So one is if the arch is big, in which case you need to do an extended arch resection. Mm-hmm. The other one is if it's a true type 2 DeBakey. And we've had one, maybe 2 of those now, where it was just really limited to and it's unusual, but it's just limited to the ascending aorta. So there's, the arch is essentially normal, and there's no false lumen in the arch. So those are the issues that we haven't used it in.
And Zlatko, the last guy that we did was a type B with retrograde dissection. Is that, do you have to have the entry tear somewhere in the proximal aorta to be able to use the AMDS stent?
I think so. I mean, I think in that scenario, this patient was a little different, right? And he was elderly. If they're younger patients, they probably should have that intimal tear removed and resected, right? So that would make it more, not really what we're looking for in these initial patients. But I think, in that setting, they probably, in general, should have a more extended arch procedure if the tear is in that distal arch. Is that what you're asking, Chris?
Yeah, that's right. Yeah, if if you haven't resected the entry tear, then the uncovered nature of this stent
No,
wouldn't necessarily
no,
promote remodeling.
no. Yeah, you need to remove that. That's still that principle of removing that. So I don't think it would help in that scenario, and I think it wouldn't be right to use it. I think that was one of the reasons, right? And yeah,
I think
go
that's
ahead.
JF has also asked that question on the chat. Can I leave some tear in the arch and cover it if the entry tear extends into the arch?
Yeah, I mean, technically no. I mean, I think that needs to be removed, and it depends where it is in the arch. I mean, if you could include it in your anastomosis, I think that's okay, and if it's of normal size. But I think you do need to stick to that principle of not leaving an intimal tear behind. I think
Yeah,
that's
exactly. I mean, what you're describing with the Dane almost sounds like this is what we don't see macroscopically.
no,
We sort of
and
assume
that's
that
what.
we've excluded everything, but there potentially is
No,
an ongoing.
no, absolutely. And you do when you do, and that's why I said this is not just an observational, anecdotal thing. Like you look at the CT, 80% of these CTs still have false lumen flow in the arch.
I'll be
You know?
devil's advocate as Zlatko, is that I wonder if many of the times we underappreciate entry and exit further down that you don't.
Absolutely.
So then in that setting, in my mind, if you have a distal tear that I can't address in the arch, why not use this?
If you have a distal tear in the
So
arch,
I've addressed the ascending aorta, let's say, and I still see that maybe I'm not sure, distal arch, there may be something that I can't resect, why not use this? That
well, that's okay.
theoretically,
But if the primary tear is in the ascending aorta,
yep.
right? You see, so that's different. So if you think the primary tear is in the arch and then coming back, like Chris said, retrogradely, then that's a problem. But
Yeah, I
if you think you clearly have seen the entry tear in the ascending aorta, a big rent, and you see a little tear, then I think that's okay. I think that's okay. I think that in that setting, you can still get positive remodeling potentially.
Because this
Plus,
is where I see the most value in my mind, because sometimes
yeah,
you just can't deal with these problems.
but if that are, because sometimes we also shy away, you know, if we don't always necessarily see that tear in the ascending aorta, and
Correct.
and then that arch tear is actually the primary tear that you can't leave behind. You have to have seen that tear in the ascending aorta. I think that's okay. I think that's okay. I think you can still get positive modeling in that setting. Plus, you also have an option down the road of stenting that. That's not that difficult of a procedure if that is a source of false lumen pressurization, and it turns out that way. So I think that is okay to do that in that setting. But in Chris's case, I think that tear was the primary tear was in the arch, so I wouldn't do it in that case.
So you mentioned size of the arch. What is the maximal size of the arch?
48 at 45-ish, 46.
Okay, so pretty big. Okay.
Yeah, so if it's, I think the one we had was 48 or 49, and I called Ali, he said, would you do it in this case? He said, no, absolutely not. So even that 3-4 millimeters, he said no.
Yep.
So, yeah. So, and I think it would be nice to if, to look at all the dissections that come in, look at the images, even just as an exercise to, determine suitability and candidacy for the stent. I think once we get our first one in, I think we'll see that, it's easy, and we can do this in a proficient manner. So I think that'd be a good way to proceed forward.
Perfect. All right. If one more question from Carol. If anyone puts the stent in, she's asked actually, so that the research team is notified, whether it be by email, text, or otherwise, so they can recruit them in the DARTS trial registry and start capturing that data. So absolutely. I mean, obviously we haven't put one in yet, but that's the intent. Okay.
Absolutely. Good. All right.
Very good. So Zlatko, thank you so much. I'll let you go, and I'll stop recording. Thank you very much.